Thank you, Dr. Hoban. It's a pleasure to be in this session moderated with you and with other participants who are colleagues and friends. I've been asked to speak about anterior segment signs not to miss. And time is limited, and I can see the ticker is going already. So I'm going to limit myself just to the iris. And what I will share with you are some signs that, in my experience, are often overlooked and not seen in the iris, but are critical to see, actually. And if we don't see them, who's going to see them? Nobody else will see them. So it's really, these are anterior segment signs not to miss. And I'll start with the case of this 16-year-old boy who was referred for reduced vision of unclear etiology in the right eye. He's 20/40, 20/20, but there's no explanation. He has no strabismus, no APD, no refractive error. He's got some mild temporal disc pallor OU, but we see that often. It doesn't mean that there's something wrong. The retina is normal. It's idiopathic. This is why he's referred. And when we look at him, what do we see on the iris? We see these lumpy lesions, almost like silly putty. Silly putty is a toy that used to be in the United States. It's like a jelly type toy. Like someone took these mounds and threw them on the iris. And they're they're different color than the brown iris as well. These, of course, are leash nodules that were not noted. And when we do a VEP on this patient, the VEP is abnormal, it's delayed. This patient has an optic nerve glioma, even though he doesn't have an APD. And even though the optic nerves look normal, it's because both eyes are affected, so there's no APD. This patient has undiagnosed neurofibromatosis type 1. Now, neurofibromatosis is extremely common. I have no doubt that everyone in this room knows somebody who has neurofibromatosis but doesn't know that that person has neurofibromatosis, because it's very common. It's approximately 1 in 3,000, and there's such a variable expressivity that some people have severe skeletal deformities, glaucoma, etc., etc. Other people just have mild leash nodules and very mild glioma. They don't even know. They go into adulthood. They don't realize they have the condition. When we have a patient who has a light-colored iris, it's very easy to see these lesions, and you can see them. It's a little bit more difficult in the brown-colored irises, but we can distinguish them. Again, they're distinct from the iris. It's like someone took some clay and threw it on, and it's different color from the brown iris. Here's another patient, 4-year-old girl, asymptomatic for routine exam, coming in because the mother has no neurofibromatosis. And you can see those leash nodules there. We just diagnosed neurofibromatosis, a genetic disease, without doing any genetic testing, just by looking at the anterior segment. An anterior segment sign not to miss. Here's a 26-year-old referred because of multiple cafe au lait spots. The primary care physician referred the patient for an ophthalmic exam. There are no ophthalmic complaints. This patient is 20/20. But look at these juicy, plump leash nodules that nobody ever saw before because no one ever looked at the patient with a slit lamp. Very powerful to look at the iris and make this diagnosis. Now, sometimes this condition gets confused with leash nodules, but you can see how it's different, right? First of all, there are so many of them. Secondly, you can see it's intrinsic to the iris. It's not like that other one that was stuck on, and it's the same color. These are iris mammillations. They can be non-consequential. You can see them in normal people. It doesn't mean that there's a disease, but sometimes we see them in hyperpigmented states. In this girl, she had nevus of Ota, and she had, in the affected iris, she had these iris mammillations. So the first iris sign not to miss is leash nodules. Now, the second is represented by this girl with nystagmus and low vision. She had a neurological workup because nobody could see anything wrong in the eye exam, but she had nystagmus and low vision. But when we look at her carefully, again, iris signs not to miss, What does she have? She has iris transillumination. This is another iris sign not to miss. Nobody is going to miss that a patient like this has albinism. A layperson will know a patient like this has albinism. But there's a lot of milder phenotypes out there where the patient doesn't seem to have decreased skin pigmentation. They have albinism, they have some nystagmus, and they have subtle iris transillumination. Iris transillumination and albinism is a spectrum. And when it's very obvious, we can all see it, and it's often with obvious skin hypopigmentation. But it can be subtle, and you might have to make the room very dark and put a slit lamp to see it with retroillumination. Any child who comes in with nystagmus, before sending them to the MRI, try to get a good look at the iris, look for iris transillumination. Transillumination defects is another iris sign not to miss. My final one is exemplified by this patient who's actually an adult, and she came in for eye exam. She didn't have any complaints, but she had a family history of a genetic disorder, so she came in, and what do we see in her eye exam? She's got iridogenesis. Immediately, we're worried about the number one cause for iridogenesis. That is the number one cause for lens subluxation, zonular weakness. That's Marfan syndrome, and sure enough, she had an undiagnosed dilatation of the sinus of Valsalva, severe aortic regurgitation, and she needed emergency cardiac surgery. This was undiagnosed. She didn't realize it. She was asymptomatic, but you see this iridogenesis, you need to work up a patient for possible fibrillin mutation. Here's a 6-year-old with high myopia. Look at the iris in the patients with the high myopia. Myopia is very common right now, but we see sometimes genetic reasons. This patient had iridogenesis. She had testing for fibrillin mutation, which was negative, but I insisted she still needed an echocardiogram. And sure enough, she had aortic dilatation. The genetic testing is not always find mutation. The clinical exam can guide you. When you see zonular weakness, the patient it's an iris sign not to miss, iridogenesis. These patients need to be worked up for potential Marfan syndrome, potential aortic root dilatation. Of course, the zonules are comprised of fibrillin, and when fibrillin is mutated, we get iridogenesis, if not frank ectopia lentis. No one is going to miss an obvious patient with Marfan syndrome. Even a layperson will get it. But again, we see these children who are otherwise systemically fine. They can just come in with the iris shaking. It's an iris sign not to miss. With that, that's the end of my time. Thank you for your attention.
Thank you for this excellent talk, as always. We learned many things, and I would like to have the discussion after the second talk. And our next speaker will be Tariq Said. He's from Cairo, Egypt, and he will tell about what's important not to miss in posterior segment.
Thank you very much, everybody, and thank you